Thanks everyone for joining us this morning. My name is Brandon Marshall. I'm a professor in epidemiology at the Brown University School of Public Health and also direct one of the cores of the COBRE on opioids and overdose, which is hosting today's webinar. I am super excited to introduce Dr. Erin Stringfellow. She's an instructor at Harvard Medical School and a research scientist at Massachusetts General Hospital. Her research has focused on empirically analyzing and testing policies with the aim of reducing overdoses. Specifically, she uses systems dynamics models to inform and identify how policy solutions and improving substance use, prevention, treatment, and harm reduction policies could address the overdose crisis in the US. Her work is grounded in the lived experience of people who use drugs, their loved ones, community service providers, and policymakers. She's done a ton of fantastic work. In particular, I'm a big fan of a 2022 paper, which I've relied on a lot to guide some of the opioid settlement spending decisions in Rhode Island. So I'm really thrilled to have her here today. We'll have her speak and then open it up for questions. The Q&A will be moderated by Michaela this morning. So without further ado, I'll turn it over to Dr. Stringfellow. Take it away.
Thank you, everyone. So Brandon's introduced me, so I don't need to say anything more about that. What I wanted to do today is to walk you through the journey of how we started with our simulation model source, which I know was one of the topics and projects that you all were interested in hearing about, and how that actually led to a paper on buprenorphine dosing, because that was something else I had heard there was interested in, because it's actually part of a single narrative. And it helps to show how modeling at multiple levels combined with empirical analysis can actually work really well together, and that's how we ideally work. So just a little bit about the development of source. It was 4+ years in collaboration with the FDA and multiple subject matter experts. There were dozens of people involved. And the standard that we really set for ourselves was, can we recreate historical patterns of initiation of opioids, opioid use disorder, overdoses? And we do that through calibrating the model, which means we are estimating unknown parameter values in order to reproduce that historical data. The key unknown parameters being things like transition rates between misuse and OUD, and the effect sizes corresponding to feedback dynamics, which I'll get to in a little bit. So we then carry those calibrated parameters forward to create projections. And if we're able to recreate that historical data, then we have more confidence that the projections that our model is creating are trustworthy. So one key difference between our simulation model and that of many others out there is that we incorporate feedback effects. So I want to give you just one example of what I mean and walk you through these loops here. So as we have, let me see if this laser pointer works. Okay. As the number of people who misuse opioids increases, so this is, we can think of this as like a snapshot in time of the number of people who misuse any type of opioid or have an opioid use disorder. As that increases, the initiation of opioid misuse also increases. And so we've labeled this a social influence reinforcing loop. At the same time, though, as people who misuse opioids increases, the number of overdoses increases. And that therefore leads to a drop in initiation of opioid misuse. So we see that with the negative sign here, they go in opposite directions. And that we have labeled a balancing loop called perceived risk. So these two are always operating, and they can't, one pushes in the direction of more use and one pushes in the direction of less use. We also have in the model this availability of opioids, which we've used data on prescription opioid volume and heroin price to try to estimate the availability of opioids over the time period of the model, which I should mention was 1999 to 2020. So this is the structure. This is one part of the structure of the model. So the question is whether this structure can reproduce behavior, which is really a key standard that we set for ourselves in system dynamics modeling. And here's how our model fit to the data for a few key variables. So at the top, we have the prescription opioid misuse initiation and heroin initiation. This paper is the first one that came out that described the model development and what it was able to do. This is from my colleague Sayang Lim. and it was in the Proceedings of National Academy of Sciences. And so, as you can see, initiation has actually been dropping for prescription opioids and for heroin for some time now. The trends are different. But to be able to replicate that historical pattern, we actually had to have that perceived risk loop that I showed you in the previous slide. So for both prescriptions and heroin, by the time initiation was going down, the total number of users of each of those opioids hadn't actually declined yet. So that couldn't explain why there was a drop in initiation. And there was a decline in availability that roughly corresponded to when initiation was dropping, but that availability alone couldn't explain the full drop in initiation either. It wasn't until we added this perceived risk loop, and I can just, this perceived risk loop here, that we actually could get these drops in initiation. So this is how we use the structure to see if we can replicate the historical patterns of the model. Of the data. So I actually consider this the most interesting figure from that first model publication. So we're showing here the simple story that the initiation is dynamic. So a lot of times we'll see in models that people will either assume initiation never changes, that we always have the same number of people every year using a new drug, or they'll assume that whatever it is now or whatever it's been in the past couple of years is what it'll continue to be in the future. But we were showing that by the time we were publishing this model in 2022, initiation was already going down and it was likely to continue to go down. And we got at that through a combination of estimating the hazard rate and estimating the population of people who are using each type of drug, again, using the National Survey of Drug Use and Health data. So why does the dynamic initiation matter? So when you put into your model what you think is going to be happening in the future, it matters a lot how many new users are basically coming online. So when we let the model use the calibrated parameter values and input data like how much availability there would be of different opioids, and we create projections, initiation and prevalence of misuse and opioid use disorder both continue to decline, which led to declining overdoses. So crucially, we were not making any assumptions that were forcing this to happen in the model. It was built into the model, this mechanistic structure, the influence, the loops influencing initiation, and we were calibrating unknown parameter values to the data. And so we had projected in 2022 that the overdoses were going to be dropping. So this figure is from our most recent paper that just came out within the last couple of weeks in JAMA Psychiatry. So it was a retrospective look at why the pessimistic version of our model in 2022 was able to predict the drop in overdoses so well. We were within 5% of the actual peak number and about 6 months of when that peak occurred. All versions of our model predicted a drop. Our optimistic version, our baseline version, our pessimistic version. The pessimistic version basically said, what if everything goes wrong? Like, what if fentanyl saturates the supply even faster than we thought it would? The rate of naloxone distribution starts to, the rate of increase starts to decline. Treatment, availability doesn't increase as much as it was before, things like that. And so we basically just said, if everything goes wrong, what could happen? And it was a very close number to what did happen at its peak. So the critical point to take away is that in our models, we tested so many different assumptions. We said, what if opioid use disorder is actually not declining, but we assume the initiation is? Overdoses still dropped. I don't think they dropped any later than 2025 in our model, regardless of the assumptions we made. So it was bound to happen because the declining initiation was leading to a declining population and therefore a declining number of people who were at risk. In our simulations, the speed of the decline, how quickly it happened, was actually governed by how quickly fentanyl saturated the supply. So that was the main factor driving our pessimistic scenario. And so that's the first thing we looked at when we started to see the actual data, because we wanted to understand why the steepness of the drop was so much faster than our model had projected. We had projected this really well, but we did not project this. We thought the overdoses would still be quite a bit higher than they are now. So my colleague Zainab Hasbul has been looking at this, and what she actually found was the only way to match this steep decline, and in this we haven't published any of this, we've just been looking into it. The only way to match this steep decline was to actually simulate the effect of fentanyl saturation in the opioid supply declining. Um, that I think is an artifact of what we actually have available in the model. What we have available in the model is just fentanyl and heroin together as a denominator, and then fentanyl as a numerator. I don't think heroin is making a comeback. I haven't heard anything like that, but we're in sort of a hypothesis generating phase. It might actually be that there's increased contamination of fentanyl, so that sort of per fentanyl dose, if you will, there could be less than there was before, and that would show up as reduced saturation in our model because we don't have those nuanced data on the entire supply. And so that could be a next step is what if we look at the supply more thoroughly? Might that be able to explain what's happening here? So, on the one hand, we had the shape right, and we had the numbers right, but we did have this underestimate, and so I think that's a key area to look into the future. I will say that we used what updated data were available. Our naloxone assumptions were actually very pessimistic, and there was more naloxone distributed than had been, like the increase was even faster than it had been in the past. But based on our conversations with folks like Maya Simpkin, she said it might actually be getting less efficient, the distribution of it. So, but we tested, what if, not what if, but actually looking at the number of naloxone kits that had been distributed, that gets this number this trend line a bit lower, but it still doesn't get it as steep as it was. We had to do things like double the number of people getting methadone treatment to get this number down. So that's just sort of an extreme test that you can do with the models. How far do you have to push your assumptions to get it to match the data? And if nobody thinks that methadone treatment doubled, then it's unlikely to be that's what caused the steep drop. So this is what I really meant in the title of the talk about the changing overdose landscape. So the underlying structure of opioid use is dynamic. It's always been dynamic. Initiation is currently falling, but it could rise again in 10 years if perceived risk starts to drop, right? The OUD population is currently falling, but that can always change in the future. And the overdose risk from the retrospective look that we took is either plateauing or might actually be falling. And so the combination of the population falling and this plateauing, if not falling overdose risk, is leading to the drop in overdoses. And it's really a question of what's happening with the supply that could be driving how steep it is. So I'm going to turn off this laser pointer. Okay. So now I want to shift to how we've used SOURCE to analyze policies. There are two main points I want to make with this. The first is that our general preference when we were finding policies to test was to be as mechanistic as possible in what we chose when that was possible. But it wasn't always. And I'll tell you a little bit more about what I mean by mechanistic. And the second is that all of our model results are relative to a business as usual scenario, which again, in our model meant that we were projecting overdoses were already going to be declining. And so for any gains we were estimating were relative to that decline. So it doesn't mean that lives weren't being saved. It just meant that the timing really mattered. And if we had done something 5 years ago, the impact might have been larger than what we were seeing when overdoses are already projected to be declining. So I'll first discuss briefly our treatment-focused modeling. So one key test in the Science Advances article that I assume Brandon was talking about was to increase buprenorphine provider capacity. So there are a couple of ways we did this. The only one that had an effect was actually to increase the average number of patients that buprenorphine providers were treating. So using a combination of existing data and literature, we estimated how many patients each waiver provider was treating. I don't remember what that number was. And then we just increased that to see how much would it change outcomes. And so the capacity expansions had a short-lived effect. It's a visible effect, right? This red line is the overdoses. So they drop by over 2% sometime in 23 or 24. And this is if you increased the average number of patients every provider was treating. Um, but the reason that the effect was short-lived, again, was because we already were seeing a decline in overdoses, and a decline in the population. So as that pressure eases off, the capacity limits that we were hitting in the model didn't matter as much. Uh, we were basically projecting there would be fewer people, new people, especially seeking treatment because the population was declining. And so it doesn't mean that adding new patients per provider wasn't helpful. It was just saying relative to what we were already projecting to happen, that wasn't going to have much of a long-term effect. So we followed up on that because we know there's so much interest in treatment and buprenorphine and methadone. We weren't able to do this mechanistic detail with methadone. There's just not the data out there that would have been able to support that. But so we wanted to look even more. So what into treatment seeking? What if we increase rates in treatment seeking? What if we increase capacity, which similar to the first paper was, the number of patients that providers are treating? And what if we increase the average duration? Because another limiting effect in our model and source is that we are assuming that when people do enter treatment, they're only staying for the average duration of time, which I can't remember if it's the median or the average, but it's somewhere around 50 days. And most research I'm aware of that says that that's not likely going to be long enough for most folks. So we get them into treatment, but if they're not staying long enough, then it only has an effect in the model for as long as they're in treatment. So this follow-up paper in the Journal of Addiction Medicine focused just on these three scenarios that we could test. So and there was not a great figure that I could copy and paste here, but the highlights really were that to achieve the maximum reduction in overdose deaths, which we actually were able to get quite a large one. I think it was 19%. But that meant we actually had to simultaneously increase duration to 2 years on average, right? From like 50 days, we had to get it up to 2 years. And we had to increase capacity at the same time. I think it was something like from 5 to 7 patients per provider. And the increases must be done ASAP, right? Back in 2023. So this was really a paper that was more showing just how difficult it would be to get these large increases, because by the time we're publishing it, we're saying you need to be doing this impossible task right now. And again, the reason that the declines, that the impact of the policies over time decline is because we're projecting the decline in overdoses in the business as usual scenario. So if we were going to maximize the effect of interventions like increasing duration and capacity at the same time, the time to do it was 5 to 10 years ago. It doesn't mean it doesn't have an effect now, but the largest impact would have been seen when overdoses and OUD were still rising rather than when they were already on the decline. So an important point here about the value of modeling and really being able to test how timing changes. I don't remember all the nuances of that paper, but I do think that, for instance, you got more of an effect with treatment seeking later as you did earlier, because that was not as dependent on things like capacity. But it's still like the biggest impacts came from getting more providers to treat more patients and getting those patients to stay in a lot longer. So I want to talk a little bit about the harm reduction strategies, because we had two key ones in this paper. We had a naloxone distribution and fentanyl risk reduction. So the more mechanistic of those two was the naloxone distribution. So we were able to include lots of details because we could turn to the literature, which is 20 years old now, on things like the likelihood of an overdose being witnessed, the likelihood of a witness calling emergency personnel or 911, the likelihood of the witness having naloxone available, whether or not they call emergency services. And then the other thing we know is that distribution does not equal usage. And so we, in the model, actually calibrated an efficiency parameter that was showing diminishing returns on each additional kit distributed if we continued using the same distribution channels that we've been using, where there's a lot of kits that are getting out there, but not necessarily to the right people who are going to use it before they lose it, before it expires, or at all. So given we assumed that nothing was going to change about how efficient distribution would be, we didn't change anything about like the likelihood of an overdose being witnessed. Those are all things that can be changed in the model. We just didn't for the purposes of this paper. And So, that means that our estimates were constrained by these real world factors that we all know exist. And if we wanted to see larger impacts of naloxone, we would want to go in and also test what if the OD is being witnessed? What if we know that the witness is calling 911? And I should mention that if that were at 100%, we assume that if they call somebody that naloxone is used. And then we also estimate a baseline risk of a fatality given an overdose, which is not 100%, right? Even with a fentanyl overdose, some people will survive without an intervention. And so we estimate that risk there. So all of these things are not, they're not assumptions because they are based on the literature, but they can all be changed in the model. But we just said, let's increase how many kits are going out there and not change anything else. But in contrast, the fentanyl risk reduction was not mechanistic. For a couple of reasons. The main one is that there wasn't the clear evidence-based corollary for the fentanyl risk reduction that we could say with, naloxone. We actually have data on the number of kits distributed, and we have a pretty good sense of how it works. With, for instance, fentanyl test strips, we couldn't find any data on how many kits strips had been distributed, how many had been used, and then there's not, at least at the time, and I'm not aware of any updates since then. We don't actually know what fraction of overdoses are, prevented by somebody using those strips. We would have had to know all of that in order to make this more mechanistic. And that was one example of how a fentanyl risk reduction might be mapped onto a real intervention. It would basically be anything where if we assume that there is some sort of fentanyl exposure, that they decide to use the fentanyl, how do you reduce the risk that they overdose? Which is different from how do you reduce the risk that they don't die from the overdose, right? So we have two separate steps in the model. One is the overdose itself, and then one is whether they die from the overdose. So we really included it, even though we didn't have this detail, because we wanted to demonstrate the impact of fentanyl and really push people to think about what is sort of the maximum impact we might be able to see if we could develop interventions that mapped onto this. I hope that we were clear that we didn't know of any interventions that could do that, but we didn't want to leave fentanyl out of the intervention scenario picture because we had all of these other things we were testing, but fentanyl was the clear driver of the deaths, and so we wanted to have something that spoke to that. But that meant that when we tested in the model, we didn't have those mechanisms like we did for naloxone or treatment to represent those real world constraints that would, almost certainly mean that anything we estimated was going to be an overestimate of the impact. But, hopefully as there are more data that can either map onto something like test strips or completely new interventions, then that can be something that would be made more mechanistic and not just our model, but anyone's model. So I now want to step outside this national model entirely and source entirely, because we also did a qualitative system dynamics project that was also supported by the FDA. Following on our work with Source, they wanted to know what can we do to increase initiation of and retention in MOUD treatment. That was not limited to buprenorphine, even though that's more in their purview than methadone is. They just wanted to know what are the complexities there. So we held interviews with people who were in medication for OUD treatment, with researchers, with folks at FDA who had any kind of role in the regulatory policies here. We were seeking to understand the complex dynamics affecting this initiation and retention, and then also whether people are actually in remission when they leave. The resulting causal loop diagram was complex. When I say qualitative, I just mean that it stayed at the level of a visual map, and we didn't simulate it. We didn't put any numbers to it. It was purely qualitative. So what I'm going to review today is just one small part of that larger complex model, because that actually led to some additional simulation work that isn't published but is really interesting. And then also there are empirical analysis of the claims data, which at the beginning I said, this is part of one narrative arc here, and this is where that came in. So the larger qualitative causal loop diagram paper was The paper was led by a former research assistant of ours, Tia Herman. It's published in Addiction Research and Theory. There's a lot going on there. It's really reflecting everything that we were hearing from people and all of these different feedback loops, really. But the one that I just want to focus on today was this question about the dynamics of MOUD dosing and punishment in clinics that we were hearing not just from the people who were patients themselves, but also providers who maybe had previously worked in those settings or knew about how that this could happen in more punitive settings. And so really, what we were hearing is that, there's on average, you could think about the physiological needs of patients. And that over time, these have been increasing because their tolerance is getting greater with use of fentanyl. And then over here, we have the dose of MOUD that they are being prescribed. Whether it's, we're really thinking about agonists here, to be clear. So whether it's buprenorphine or methadone, what is the dose they're being described? Let me turn on the pointer again. And then as their physiological needs, their sort of opioid tolerance, if you will, as that goes up, the gap between that and the dose is going to go up unless the dose rises to meet it. So these goal gap structures in system dynamics are really common, where we're kind of identifying what is not, where is there a gap that might be driving some behavior in the system. So the larger this gap gets, and this is sort of our modeling language placed, that was translating what people were hearing from us, right? And so they were saying, if I'm not getting what I need from the clinic and I'm still in withdrawal or still having cravings, I'm going to go out and use more. And they were saying it's not just opioid use. I'll use other substances too. But the opioid use was at least in part making up for the gap in dose. And if they're in a setting, a setting that has really high expectations for compliance, where they show up on time and they show up for every appointment and they're looking for jobs and they're doing all of these other things and they're supposed to never be using any other drugs. And they're in a setting where the dose maybe is just sort of arbitrarily capped at a certain level that is not going to meet the needs of most patients. If they're in all of those settings and they're using, then that means that there's a greater likelihood that they're going to be seen as not compliant. They're not meeting the expectations of that clinic. And then that increases the use of punishment for failed compliance within that clinic. And one of the things that people were talking about happening is that they would be punished by having their dose decrease. It wasn't always put in those terms. Sometimes it was put in terms of safety, that, well, if you're going to continue to use fentanyl, I'm worried about your methadone dose, and so we're going to lower it, right? So it's not necessarily, it was seen as punishment. It might have been a safety concern. Regardless, what happens is that this creates a reinforcing loop. Because obviously if their dose is decreased, then the gap just goes up further. And the other thing that's not shown here, but is that use of punishment goes up. That can also include being discharged prematurely from the program. So obviously that doesn't help either. So basically, this, sorry, let me turn off the pointer again. So that led me to work with my colleague Zainab again, because I wanted to look more specifically at this role of this opioid gap, if you will, the gap between their dose and what their body needed, and a larger concept of the benefit versus burden of treatment that we were thinking about, because we were really trying to get at what leads people to stay in treatment versus leave treatment. What we were hearing a lot is that the burdens of treatment can keep going up and up. Like if they have these high expectations for compliance and they, need to be going there daily, it's a long visit or a long trip to get there. It's costing them money. They're not able to do anything else with their time. Then the burden is going up and up. And if at the same time they're not getting much benefit because the dose actually isn't even meeting their needs, then it's really a rational decision at a certain point that the benefits are not outweighing the burdens, right? But then we were hearing in the other direction that the benefits can show themselves if people can stay on long enough to be able, and they're able to find other things to do with their time because they don't have to worry about finding drugs, then they start to focus on longer and longer term goals. So that's qualitatively what we were hearing. And then we wanted to just see, what does this look like in a really simple simulation? So this is a very different type of model than SOURCE. SOURCE, like I said, we're trying to replicate historical patterns at the national level with 20 plus years of data across, I don't know, 15 time series or, using lots of other inputs. And this is just using, sort of abstractly speaking, how do these dynamics work? So one of the things that was, that became apparent very quickly with this model that we developed is that even just a little bit of exploration, we're already seeing that the results are quite subtle and demonstrate the complexity of just this small part of the system, just this like opioid need versus dose and how that's affecting behavior, and which is exactly why we use simulations. Once you get interactions between multiple factors and multiple loops, it really is impossible to predict what might happen. So the figure that Zainab produced here just shows how if you look at the combination of patient stability and then the orientation of the clinics, you get different dynamic patterns. So what we were hearing from people is that they kind of had their own threshold of stability below which they felt like they needed treatment. If they were getting less and less stable, that's actually when they decided that they needed treatment. So the threshold is the same here. It's showing it as a dashed line down here, but it's solid up here, this purple line here. And then if you're in a high abstinence-oriented clinic, your stability actually declines over time because, again, you're being punished for not meeting all these expectations, and you're not abstinent, and maybe your dose is being lowered, or you're being discharged and your stability is declining further. And none of this indicates, according to the way they talked about it, that they actually don't want to be in treatment. It's rather just that they can't stay in treatment because of all of the expectations being placed on them. And it's not giving them the benefit relative to the burden. And so their stability is declining, but it's still below where they want it to be. And so they actually would, want to be in treatment if only it could actually help them. That's in contrast to somebody who starts at the same stability threshold. They also felt the need to go into treatment, but they're in a low abstinence-oriented clinic, the blue line. And this one, we sort of set the baseline to be that if it's low abstinence-oriented, they're willing to go to a higher dose. They have fewer rules that you can get discharged for. And so this allows somebody's stability to grow over time. But what's interesting about this is this doesn't necessarily mean a longer time in remission, right? So because their stability is now exceeding the threshold that they set for themselves personally, where they said, this is how bad it has to be for me to be in treatment and to think I need to be in treatment. As this increases, they might actually not perceive the need to be in treatment anymore. And we were hearing that just as much from providers, especially, that people would start to do better and they felt like they were doing okay, and then they wanted to leave, even if the providers didn't think that they were ready yet. So we can see two separate reasons why retention might decline, and really talking about different patient populations here and different clinic orientations. So all of this is actually what led to the paper in Addiction, where we were looking at the association between buprenorphine dose and the duration of the treatment episode using the IQVIA claims data. I was really intrigued by this combination of the qualitative work pointing to the dose specifically being a real issue, and then which of course is consistent with a growing body of literature that, especially in the fentanyl era, people are just not getting enough medication. But plus the simulation work showing these complex interactions when you just adjust a couple of things and you're looking at patient stability and where they want to be in the clinic's orientation. And so we follow this up with an empirical analysis where we found that the higher buprenorphine doses were statistically significantly associated with better retention, that the effect sizes were rather small, but this is a very large data set. And what we were able to do with this that hasn't been done in prior studies is just because there were actually enough people getting 32 or 40 milligrams of buprenorphine naloxone that we could actually compare their retention to those getting 24. A lot of studies don't have that sample size, and so all they could do is compare maybe 24 to 16. Most of the literature is actually comparing 16 to below that. And we were seeing that that even going above 24 was getting some benefits in terms of how long people were staying in treatment. So this is just one small part of that puzzle, right? But it was a really like clear way for us to align what we were hearing qualitatively, what the simulation was showing us, and what was emerging in the literature that keeps pointing to this issue that dose adequacy really matters for retention. So putting all this together, the national model is showing these population shifts. That we're seeing that in the data as well, obviously, with initiation and prevalence of misuse and OUD. There's these changes in supply. At the clinic level, the modeling and the qualitative work revealing these sort of micro mechanisms of stabilization and the benefit versus the burden of treatment. And then these empirical tests that, are whether the mechanisms that we're revealing through qualitative work or that we can't quite get at in the national work, do they show up in data too? So no single model, no single set of papers from a single model can answer all these questions. We really need to have all of this together to have sort of this more complete arc, which is by no means complete, should be clear, but it all has to fit together, right? And then just to highlight that this is the ideal way that we work with simulation models, leading to some intriguing results, and that leads to some insight, and then we might follow up with data analysis, and then we build a new model or revise the existing model. It's multiple levels, it's iterative, and we're not using just one approach. So just in closing, I guess it goes without saying we're not modeling the same epidemic from even 2 years ago when overdoses peaked. The underlying structure is changing. It will continue to change. And, I mentioned briefly a couple of future directions possibly for us, but, what I really wanted to do today is have a discussion and answer questions. So, really fully exploring the steepness of the drop in overdoses. What other ways might we be able to are there any other ways that we can reproduce the steepness, or does it come down to the drug supply, and do we need to be thinking about different ways of representing the drug supply in our model? And then, in preparing for the talk and looking back over the work that we've done over the last several years, I remember this interesting work we were doing on this benefit burden trade-off with treatment and this sort of opioid gap. The clinic orientation, the client stability, like all of those factors interacting together. I'm not quite sure where we might go with that next, but I just remember that there was something there that I think is worth picking up on. And then I just want to say thank you to everyone else who's been involved in all of this work. Sorry. Mohammed Jalali was my MJ. He was the PI of the FDA studies. Sayan Lim was the lead modeler on the PNAS paper. Has been involved in a lot of our work since then. Celia and Kathy were RAs at the time of source development, and now they're PhD students doing their own modeling. And there's a huge team of people, so many RAs and subject matter experts and folks from FDA. On our team now, we still have Zainab and Hassam, who may or may not be on the call. I know Hassam is, who are both excellent modelers, and Huru Dong, a biostatistician and epidemiologist who is also, of course, doing amazing work. And then Tia and Hannah were RAs with us. They're not working with us now, but they've been involved in all of these projects as well. All right, and with that, I will take questions.
Phenomenal talk, and
thank you.
Very interesting. And what I really liked about it is not just, the modeling is cool stuff, but the fact that you're doing quality, you're actually talking to people, you're kind of listening to what they say, because I think a lot of modelers sort of miss that connection. Like, what is going on in a methadone program? And it's not too hard. You don't have to talk to too many people to know that there are programs that are punitive and that people don't feel like that, and they're getting jerked around, and they feel like their dose is not right. So I don't want to monopolize all the issues, but all the time. But I have a couple of, that the notion that the more punitive models of methadone treatment our decreased retention is not surprising to me or to probably to anybody
Mhm.
working in the field. But what what I would love to see modeled is something looking taking a further step out, because that what's happening with an individual patient in a methadone program is a microcosm. What's happening in the big picture is the whole war on drugs. The whole thing is punitive. So
Yeah.
it's not, so if we, I would love to see a model that says, gee, if we had come into this crisis without high rates of incarceration for drug possession and drug use, with actual treatment, with treatment that people would get retained in, that people would have use the other time in their life to do things that are rewarding, that and get the appropriate mental health care. Like, it's Pollyanna-ish, but if we had done this, and of course, where does all this punishment come from? Where does all this, how come you say drug addiction and everybody thinks, they envision somebody behind bars? Like, a drug addict is someone that needs to be locked up. It's not a cancer patient who needs actual treatment and care. It's, that's cultural. That's, that whole stigma. But I think if there's some way to model that and say, gee, actually, if we keep locking people up, yeah, they don't retain in treatment and do the things we want, and they actually use more, and
Yeah.
and then go back to using more and breaking more rules and being non-compliant, as you mentioned.
Yeah.
So that's one.
Yeah. And that larger CLD that Tia published, stigmas is definitely it's in there. It just wasn't in that small little piece that we looked at. But ultimately it was driving like the orientation of the clinics and the incarceration piece. I mean, you're absolutely right. And it comes up every time we talk to people. So yeah.
We have Portugal as an example. They still have some stigma there, but it's much less. But they have much lower rates of incarceration, much higher rates of treatment, much higher. And they,
Mhm.
when COVID hit, we our overdose rates went way up.
Yeah.
We had a lot of people that had their recovery support just taken out at the knees, and people lost connections, and it went up for a number of, in hindsight, predictable reasons. Um, in Portugal, it didn't. It didn't. There was not a bump in overdose deaths,
Okay.
and their overdose deaths are nothing compared to what we have anyhow. But and they didn't have fentanyl. But the point is, they've changed their culture in the last 2 decades,
Yeah.
and they don't have this. When you find out that your neighbor's kid has addiction, you try and help them. They welcome help. You bring the lasagna, just like you would for somebody has a terrible disease. You want to help them, and this is a terrible disease, but that's not the way. Nobody brings lasagna because your kid got diagnosed with opioid use disorder. Um, Anyhow, that's one thing. A little question. You talked about buprenorphine doses above 24 milligrams being
Mhm.
more protective, and I'm just wondering, is that based? I'm thinking about because buprenorphine is highly diverted. It's generally not sold. It's not as lucrative. So, but
Mhm.
I'm thinking that if somebody has, you know, if they're getting uh, 16 milligrams and they need it and they're taking it, and maybe it's not enough, or they fall out of care, but somebody's getting 24 or more,
Mhm.
and they're diverting half of it. They're going to keep going. They're going to look like they're staying in treatment, although they're
Mhm.
using it as a way to generate
Yeah.
income. Um,
Yeah. Yeah, no, we've talked about diversion a fair amount. The FDA has concerns about that. Yeah, it absolutely exists, and certainly talk to people who think that they were getting their doses were too high, and so they were taking what they thought they needed and giving the rest to somebody else.
yes.
Yeah, what
Well,
I would love to see is more research on, um, I know that it's out there, but just actually understand like qualitative studies, qualitative CLDs just on those diversion dynamics to really understand,
Yeah.
um, you know, is there sort of like a threshold where because it was a similar issue with the opioid diversion is that there wasn't enough research to really understand is it like the sheer volume of pills out there or is it that people are getting too high of a dose there and that could shift the diversion dynamics so
Sure. Well, the fact that there was so much opioids prescribed
Mhm.
and everybody paid the
Mhm.
$8 for their copay, so they didn't want to, even though they took one and it got nausea, they didn't want to throw it away. So you can
Yeah,
go into any, during that time, you go into any medicine cabinet in any house in the country,
yeah, yeah,
and there's opioids there. So that just ramped up the exposure.
yeah,
And the people that were vulnerable, they might, if there wasn't that much opiates in the whole environment, they might never have been exposed. But then
Mhm.
they got exposed to,
Right.
to opiates. They were
Yeah.
vulnerable. And then off to the races. That's another question I have is there a good measure of new initiates of the quantity
Mm.
and something more about them? I keep asking people, who are the new initiates in Rhode Island now? I
Of which
don't
substances?
opioids,
Oh, okay.
and um, because I have a feeling that when people get onto it and they get hooked, they don't dabble for a year or two and then
Mm.
kind of slide into it. If they're vulnerable and they get it, they're off to the races. Um,
Yeah, I mean, we sources at a national level, and so we just relied on national data. We were going to be developing a state level model, and I think there might still be some work heading in that direction, but that's obviously a lot more work. And then the state level data is not going to be as trustworthy, especially with cuts to the infrastructure that actually collects all of that data. So I hate to say it, but this might be something that falls on the states again,
yeah,
to just get a better sense of, all of the substances, right? Whether it's opioids
yeah.
or meth or cocaine.
All right, I will stop monopolizing your time, but thank you so much, and
Thank
I'll probably
you.
circle back.
Sure.
If folks want to raise hands or come off mute to ask questions, please feel free.
All right, then I'll circle back to one thing you mentioned that the DEA was concerned about diversion, and I just want to point out.
FDA.
Sorry, yeah.
Yeah.
Oh,
I
the
mean, probably
FDA.
DEA too. Yeah, but it was the FDA we
Oh,
were.
okay. Um, I think the DEA is concerned about diversion because
Mhm.
they got burned on oxys,
Mhm.
and but the diversion that we've seen and has been studied about buprenorphine is really very different than pure agonists,
Yeah.
and it's often more like, oh man, you're hurting, here, have some of mine, so you can get out of
Yeah.
withdrawal. So it's not
Yeah.
people. If people want to get high, they don't go after buprenorphine. They go
Yeah.
after an agonist. If they want to get out of
Yeah.
withdrawal, they'll take a buprenorphine. So, um,
And I just wanted, I mean, the FDA does have a nuanced view of this. They've talked to a lot of pharmacists, and I think what they were hearing is, I think they called it a chilling effect. So their concern was actually that with the attention to how much diversion was happening, that was actually scaring pharmacists off from being willing to prescribe it. So there was another loop there where um, because there is going to be some diversion, and then that sort of spooks everybody, and
yeah,
then that can actually reduce the number of people willing to either prescribe it or to stock it.
yeah,
But that's actually going to increase the distribution, right? Because you're not getting as many people the help that they need. So yeah, that their concerns were around like how do we stop that? Right? That sort of not have so much fear that a lot of the conversations we were having in that bigger part of the model are about fear that pharmacists were having, that the potential prescribers were having, whether or not it was based in any reality that just you know of either really from fear of the DEA fear that they would become the place for patients to come to. And then, of course, that's rooted in stigma. So
Yeah. Okay, so what are the relative contributors to this recent downturn, and and how powerful are they relatively? Because yeah.
so I don't know that we've done anything where we've said, this fraction, is attributed to this or versus that. Our modeling back in 2022, we were only using data through 2020, showed that the downturn was going to happen. It was going to happen by 2025. It was just a question of when was it going to peak and how much. And like I said, our pessimistic scenario was the most accurate. And that was really driven by fentanyl and how quickly was it going to spread through the rest of the country and therefore rapidly increase the mortality risk among those using. But those using was declining, right? So you have a population that's falling, and the overdoses had continued to increase only because mortality risk was continuing to rapidly rise. But at some point, it has started to plateau. And the question really is it only plateaued or has it actually fallen? And that comes to, like I said, what is happening in the drug supply, which, we monitor other people's work, but we don't do that work ourselves. We use national level data for source. We've looked at the drugsdata.org, and we've looked at Tracy Green's work and things like that, but and Navdesk Gupta's too, but that's sort of like piecemeal, but really that's what we're trying to understand. It seems like the steepness of the drop really has something to do with what's going on with the supply. And if you have any insights into that, please share.
I don't, but and unfortunately Tracy couldn't make it today. But the when you talk about those people using decrease, is that they decreasing because they stopped using, or are they decreasing because they're dead, or both?
Both.
And what relative proportion do you think?
So we estimate some of the hardest parameters to estimate for us were remission rates. The research is just not great. So we do estimate that some fraction of people remit and stay remitted, and then of course we peaked at over 100,000 was all overdoses, but tens and tens of thousands of overdoses every year, and then it's declining because there's not as many new people coming in, right?
Yeah.
So even if with that decline, we might have stabilized a bit if nobody was dying and nobody was remitting. Yeah. Our population might have plateaued. And we did test versions of the model where we said, what if the population isn't declining? What if the only thing that leads them to leave this stock is death, and they're not actually remitting for very long? But we still had a decline in overdoses because of the decline in initiation. So, another area of research that would bolster all of this is understanding remission now, not remission in 2000 or remission in the 90s, which is when so many of the studies were from, but what does remission look like now? Sure.
Well, I think getting the word out about what's in drug supply, which is partly related to the fact that there are a lot more nasty things in the drug supply now than there have been in the past. I've heard quite a number of patients saying, I can't do it anymore. I don't know what's in this. I'm not even getting fentanyl, and if I could use the good stuff, I'd still use. But if they have any sort of component of ability to stop using, they do.
Right.
Great. Well, I think we're right at time, but thank you so much. Anyone else have any last questions or thoughts? Keep up the great work.
Thank you.
Thank you so much, Erin.